Good afternoon, everyone. My name is Chris Brown, and I'm thrilled to be able to spend this afternoon going through our standard changes from 4th to 5th. I'd just like to acknowledge our country, if I may. We acknowledge the traditional custodians of this land, and we pay our respects to their culture, their people, and elders past, present, and future. So we shall now move on with our program. Is there anything, Tanya, that you need to say before we start, or you're all ready for me?
No, we're all right to go. Thanks, Chris.
Lovely. Okay, so as you will have all heard, my name is Chris Brown. I'm an AgPower surveyor, and I'm also a practice manager working with a number of practices. I've been surveying practices now for about 16 years. So I've seen all the changes from first standards now through to our 5th standards. So if there's any questions or queries that anybody has as we move on, please let Tanya know, who will ask questions during the presentation. And at the end of our presentation, we will have some time to discuss any thoughts that have come up whilst we're going through our program. Give me 2 minutes to just see my screen so that I can actually see what I'm needing to be doing. Okay, an overview of what we're going to do this afternoon is that we're going to look at the revised structure of the standards. We're going to look at some of the new criteria, and we're going to look at how we're going to be reading our new standards book to be able to understand our mandatory inspirational indicators and how we're going to be looking at the changes from the 4th to the 5th. The purpose of the standards is that we are needing to protect our patients from harm. We're wanting to improve the quality and safety of general practice, and we want to provide our practices with a way of identifying and addressing any gaps that they may have in their systems and their processes. If we compare the 4th and the 5th edition standards, in the 4th we had 5 sections. We don't have any sections in the new one. We didn't have any modules in the 4th, but we've got 3 modules in the 5th. There were 15 standards. We now have 17. We had 41 criterion. We now have 44. But the good part is that the indicators have been reduced. So we have 142 indicators left over from our 4th, and we've cut these down to 123. So what this means for our practices is that we have done a lot of remapping, a lot of restructuring, and we've pretty well rearranged things, but essentially the 4th is not much different to what we're now doing for the 5th. So if your practice has gone through 4 standards, you will find that a lot of what you use for your accreditation and your processes then are going to be carried over to the 5th edition. If you have a look at the screen at the moment, you've got the 4th edition. We had 5 sections. We had practice services, we had rights and needs of the patient, we had safety, quality improvement and education, practice management, physical factors. But in our new standards, we have just 3 modules. We have a core module, which is for everyone, basis, quality improvement module, and we have a general practice module. The core module has 11 new indicators, the quality improvement has 2, and the general practice has 7. So our training today is going to focus on the new indicators in the 5th edition. There are certain concepts, as I mentioned, under the 4th, which have been carried over to the 5th. So they're not going to be new to those of you who are familiar with the accreditation process. So module 1, core module, known as C. So what we've got that's new is C1, communication and patient participation. There's 3 new ones in this. C2, rights and needs of the patient. There is 1 new indicator. C3, practice governance and management, 3 new ones. C4, health promotion and preventative activities. There's one new indicator. C5 is clinical management of health issues. There's one new one. C6, information management. There's two new ones. And C7, content of patient health records hasn't changed. And C8, the indicator, education and training of non-clinical staff, also has not changed. Just to give you an overview, we've got the core module, which is going to be remaining the same. We've got quality improvement. I just want to give you a heads up, this general practice module. The idea being that as we move forward in our standards, if I was going to be doing an accreditation on some allied health, some dental, some prisons, some other areas, we would take out the general practice module and we would put in its place the module that belonged to the other facility that we were looking at. So this is why we've sort of divided them up. Core module, quality improvement, and for us, we're looking at general practice. Quality improvement, there's one new indicator. Clinical indicators have stayed the same, and clinical risk, we've added an extra one for you as well. In the general practice area, we've got access to care remains exactly the same as it was before standards, but the comprehensive care, there are two new indicators. Qualifications of the clinical team, there are two new ones. Reducing the risk of infection, one new one. Medical practice, one new, and vaccine potency, one new. And these are all the new ones that we're going to focus on this afternoon. And to give you an example of how we read this, so if we were looking at C6.4 and an F with our little flag, it says our practice has a policy about the use of email. Now this is new. We didn't need to have this last time. So the standard is C6. So it's standard 6 in the core module, which the core module in this instance is information management. The criterion is 4. So it becomes C6, therefore standard 6 in the core module. Criterion 4 in standard 6, which is information security. And the indicator that we need to ensure in our practices that we actually have met this is C6.4F. Indicator F, our practice has a policy about the use of email. So that's how we're reading our new standards. I'm hoping most of you have a copy of the new standards and you're familiar and have flicked through the new standards and the way it's written. So you'll see it will be C6, 1, 2, 3, etc., etc. Mandatory and aspirational. Those of you who have done 1, 2, 3, or 4 know that if anything is what we call flagged, it's mandatory. So indicators that are marked with a flag are mandatory. These must be achieved to make sure that we meet accreditation requirements. If there's no flag symbol next to an indicator, it means that the indicator is what is known as aspirational. So again, just as a reminder, remember back a number of years ago, we had noted in our standards that we all needed a height adjustable bed. There was no flag next to it. It was letting us know that we'd like you to have one, but you didn't have to have one. And as we moved from 3rd standards to 4th standards, we must have a height adjustable bed. That then became a flagged indicator. So this is the same through into the 5th, that we have mandatory, flagged items we must do, and those with no flag are aspirational. Practices are encouraged to meet the aspirational indicators, but it's not essential to meet the requirements of accreditation. The other change that we have in the new standards is that we have blue and black text. So the blue text highlighted demonstrates evidence which must be provided to meet the indicator and uses the terminology must. The text in black is a list of suggested options of how to meet the indicator and uses terminology such as could. So we now have coulds, woulds, musts, may, can, So we have a lot of different criteria. So you'll notice as we move on, we've got could, meeting the indicator. The list is not exhaustive. Practices are encouraged to develop your own methods that suit your own practice needs. The college has clarified that in meeting the criterion section, the words needs and must are used interchangeably and therefore they mean the same. Have I confused you completely? Yeah? Good. We'll get on. So this is how it looks in the standards. So example of blue and black text. C64F, our practice has a policy about the use of email. You must, in blue, maintain an email policy. In black, you could put your email policy on your website, have an automated response to patient emails that advises them of when they are likely to receive a response. It then goes on for us to have to work out how are we going to interpret what this is meaning. So outcome-focused accreditation, we're interpreting the intent of an indicator. So practices need to consider what is the purpose of the indicator? How does this indicator enhance quality and safety? How are we currently addressing this intent? How could our practice improve how we're meeting the intent? Who should be involved in the process? And what evidence will we provide in demonstrating that we are meeting this intent? So we then look at answers to those questions we've just posed. Patient-centered outcomes is our main focus. So the intent of our standards is making sure that our patients, their families, are in the forefront of our healthcare, that they have the ability to make choices based on informed decisions, that patient engagement empowers the patient and their family in their healthcare. Patient-centered outcomes mean that the indicator focuses on what the patient receives rather than what the practice does. So we're stating we need to have an email policy, but we're needing to have a look at how is the patient going to get that information. This includes educating our patient. We need to inform them of what they may encounter when they're accessing medical services. So the shift between fourth and fifth is process-focused to outcome-focused. Previous editions have dictated how we should demonstrate compliance with the standards. So as an example, if you remember, we've always been needing to have a practice information sheet in our practices that tells the name of the practice, where we are, how to contact us. And there was a list, which we'll come to in a moment, that stated you must have the name of the practice, the address of the practice, and how you're going to do certain things. The shift that we've got to being process-focused is we can give that information in any way that is suitable for our practice. We still need to have the same information available to our patient, but we can put it up on our web, we can have a printed sheet, we can use different means of getting that information across. So we can now demonstrate how we meet the intent of an indicator, and provided that your team can explain to me, a surveyor, when I come to your practice and give me enough evidence that I'm satisfied that you understand the intent of the indicator, you're then assessed as meeting the indicator. So this becomes a lot easier for practices to maintain continuity after the accreditation process. As a surveyor of first, second, third, and fourth standards, I've gone into lots of practices where we walk in and I have all this beautiful documentation meeting exactly everything that I need to see. But I know when I walk out of that survey, those beautiful folders are going to go back up on top of the shelf. They're going to be just put over there, dusted off in 3 years' time and looked at. And what we're trying to do is encourage our practices to be able to continue the meeting standards, of looking at the bar, of being able to understand how we're going to support our patients in a manner ongoing, not making it difficult that, well, we had to have our staff go through a performance appraisal process. We don't really do a performance appraisal process because we just talk to each other, but for accreditation, we've got papers that say we do it. Under the fifth, we're hoping that it's going to be something that you're going to see, hey, it's actually quite easy to continue doing evaluations of the staff and do quality improvement. And that's what today I'm hoping is going to give you that encouragement that this is actually not going to be difficult at all. So at the bottom of our slide, it says our practices must still incorporate the "you must" within their approach, which are highlighted, remember, in our blue text. So what does this mean for our practices? Having documents, as my example, and policies in itself does not mean that the practice is actually meeting the underlying intent of the indicator. So example, with my example of the performance appraisal, the intent is that we're monitoring how our staff go, assessing how the practice is meeting certain quality improvements. Just because you show me a document that says you've done a performance appraisal did not meet the intent. So this is now where we're going to look underneath what the criterions and the indicator are to learn what the intent is of these standards. Some indicators, practices cannot meet the desired outcome without a policy in place. In these cases, it will state quite clearly you must have a policy, i.e. the email example at the very beginning. So our practice information sheet, really good example of the changes. So in Standards 4, as we discussed, our practice information sheet is available to patients and is accurate and contains at a minimum all of these dot points. As a surveyor, I needed to go into practices and I would have to look at your practice information sheet and I would have to tick a box that stated the address and telephone number was there, consulting hours are there, the billing's there, excuse me, the billing is there, communication policy, etc., etc. I had to make sure, and if just one of these dot points was not there, then the practice information sheet was not met under the 4th editions. Under your 5th editions, we've got C1, communication and patient participation. I might have jumped a slide, apologies. Under the new 5th edition, it's the same information that needs to be given to your patient, and it's now C1.1a. Our patient can access up-to-date information about the practice. At a minimum, this information contains same dot points, our practice's address and telephone numbers, consulting hours, details of arrangements for care, billing, names of our practitioners, our communication policy, how do we return phone calls, a policy for managing health information for our patient, or the principles on how the details can be obtained, how to provide feedback, how to make complaints, and the details on the range of services. Same dot points, but in a different way we're going to look at it. So the new modules, the new indicator in the core module is that C1, communication and patient participation. C1.4c says, our patients can access resources that are culturally appropriate, translated and/or in plain English. C2 is the rights and needs of our patients. So C21E, notice this is flagged. C1.4c is not flagged, but C2.1 has a flag next to the E. Our clinical team considers ethical dilemmas. C3, again, this has got a flag next to C3, 1A. Please excuse me. Tickle. Our practice plans and sets goals aimed at improving our services. C3, 1B, no flag. Our practice evaluates its progress towards achieving its goals. Please excuse me one moment. My apologies. Sorry about that. Our practice plans and sets goals aimed at improving our services. And C3.1b, our practice evaluates its progress towards achieving its goals. These are the new indicators. There's more new indicators here. So C3, practice governance and management continues. C3.1 flagged. Our practice has a business risk management system that identifies, monitors and mitigates risk in the practice. Now you might say, this isn't new. We've had to have risk management before. But in your 4 standards, it was clinical risk management, which you still have, but this is a new one. We're now talking about business risk management. And C6, information management, C6.4F flagged. Our practice has a policy about the use of email. We also have G, our practice has a policy about the use of social media. So some of these cross over from last standard, some of them don't. So let's go back to our C2.1 flagged E that we just mentioned. Our clinical team considers ethical dilemmas. I was talking about the intent earlier. We need to look into what these criterion, what the indicators, what they're meaning. So the intent of this is that our practitioners often need to manage ethical issues and dilemmas in many different primary healthcare settings. These can range from bioethical dilemmas, including end-of-life care and pregnancy termination, all the way down to receiving gifts from patients. Now, when I presented this at a workshop in west of Sydney last year, I had a number of doctors in the room and a number of practice staff that all said, well, can't we get our Christmas presents? Can't we get our bottle of wine? Can't we get our chocolates? So this is where you as a practice need to understand the intent of ethical dilemmas. So we're going to do a little bit more about ethical dilemmas as we move on. So I just want you to tuck that in the back of your mind, and we'll come to that again in a moment. So you must document any ethical dilemmas that have been considered, the outcome or the solution. You could, remember we talked about there's musts in blue, but then the new standards gives you lots of support, lots of ideas, things that you may not have thought of, and you may have thought of a number that aren't even in the standards. You could develop a policy or a procedure that explains how the clinical team must manage ethical dilemmas. You could discuss ethical dilemmas at a clinical team meeting. You could provide a buddy or mentoring system in which ethical dilemmas can be discussed. You could use a clinical intranet or group email to pose common ethical dilemmas and solutions for the clinical team to consider and discuss. You could display a notice in the waiting room listing ethical dilemmas that practitioners sometimes encounter and how they generally deal with them. Example, referring the patient to another practitioner or clinic, or politely refusing all offer of gifts. The practitioner, during the interview that they will have on the day of your accreditation, will be asked, do you have a system or a process for managing ethical dilemmas? Do you document any ethical dilemmas that have been considered and the outcome or the solution? So there's a lot of different tips in your standards. When I've done my surveying, I'm surprised at how many practices I go into and I ask have you got a copy of the standards? And I'm told, oh, no, we just went through the accreditation pro and ticked all of our boxes. It's really useful for you to have a read of the standards because there is so much information, so much help, so many guidelines to help you manage in working through what the intent is and your system to be able to meet these indicators. Why consideration of ethical dilemmas is important. Practices need to have a process to resolve ethical dilemmas in a timely way. Ethicals may arise when considering decisions not to treat a patient, decisions to withdraw or discontinue treatment, or decisions to provide treatment against the patient's wishes. I have, in my practice, we, as all of you do, this is new for all of us, this ethical dilemma. Something that we've always known it's there, but we haven't had to show the way we manage ethical dilemmas. Oftentimes the doctor themselves has been the sole person trying to get their mind around how they're going to manage the ethical dilemma that they're faced with. So we need to be opening the lines of communication that this is a subject that is safe to be discussed within the practice setting or the clinical setting. If you're a large practice and you are having your clinical team meetings, to put ethical dilemma questions or queries on your agenda, just to raise it, not wait until an ethical dilemma arises, but actually have it there that you can talk about what is ethical, what is an ethical dilemma, what are the possibilities, what have you maybe met before. If you're in a small practice, the same thing happens, but only in your team meetings with your staff, your practice nurse, your practice manager. But we also need to allow our reception staff as well to be able to discuss ethical dilemmas that they may come across or how they can support the practitioner. So in my practice, we have now added this as an agenda item, ethical dilemmas, questions. We put up some possibilities so that we're all becoming very comfortable with discussing this before it becomes something that we need to manage. Examples that we've got are the patient-practitioner relationship, family relationships, friendships, romantic relationships, allocation of healthcare resources, bending rules, example, giving medical advice to family or friends, career and training decisions, consent dilemmas, cross-cultural issues, discrimination against patients, doctor health and life balance, which is very difficult, and doctor social and political responsibilities. We go on to say impaired colleagues, professional differences, receiving gifts from patients, emotionally charged clinical situations, when a patient has an unwanted pregnancy or terminal illness or wishes to discuss euthanasia, end-of-life care, reporting to the state's driver licensing authority that a patient is unfit to drive, or a patient's request for a medical certificate if the practitioner does not believe that the patient's condition warrants one. I'm sure that most of you have come across one or more of those examples in your years of being in a medical practice, whether you be a practitioner, a nurse, a practice manager, or a receptionist. Those issues do come across. I just want to talk a little bit about the gifts. I love my gifts at Christmas time. I'm sure you all do. I think it's great. It's the way the patient says thank you. If there's no untoward intention other than a thank you, there isn't a problem with receiving gifts from your patients. But if your patient brings you a gift, and with that there's a little bit of a tagline in that you'll now fit me in whenever I ring up and need to have an appointment, or if there's an expectation because you've received gifts from particular patients that you will always be available for them. And this is why we suggest you need to sit in your meetings and discuss all of these. Most of our patients come, I know in my practice, there's one particular dear lady that every time she comes, she brings us in homemade muffins. They are beautiful. There's no way my girls and I are going to say, no, thank you, no muffins today, it's a gift. She does that because she is very grateful to the care that we give her, the support that we give her, and it's her way of saying thank you. It's got nothing attached to it that says we have to always look after her. So that's the kind of thing you need to think about. So we're not saying you can't have gifts. You need to work out why you're getting the gifts. Are they expecting that you're going to drop everything and run because you've received a bottle of wine or chocolate biscuits at Christmas time or on your birthday? Is that making sense to everybody? Give me a wave if that's okay. Everyone's right with that one? Excellent. Good. Now, we've got an activity that we're not going to do today online, but I'm hoping that you all received a copy of a particular chart in your packs that you received today. And I encourage you, whether you're going to have time to do this later as a group or to take this back to your practices and to actually have a look at this. Please excuse me again. My apologies. So we have that sheet there, and I'd like to ask you to actually have a look at going through this and thinking of different suggestions that we put there. Feed it back with your group. It's a very, very good tool on getting your mind around the different ethical dilemmas. The one that we're going to just put up here, though, for you to just think about, I'm just going to talk to, is that an ethical dilemma example is that the doctor identified an elderly patient who was unfit to drive, but they were, as I'm sure you all have been, faced with the dilemma of reporting the driver to the state driving licensing authority. The doctor, who had been with the patient for several decades, knew that reporting this driver would affect their independence, their overall well-being, and felt a sense of loyalty to the long-term patient. Now, I can speak on this one actually personally. My mum is 88, and I'm not getting in the car with her. My sister won't get in the car with her. None of us would get in the car with her. And the doctor kept signing the papers and saying, yes, she can drive because she needed her independence. It ended up becoming quite difficult, and we needed to sit down and explain why there were concerns. And my mum would come in and she'd say, oh, Christine, I can't see that. And we think, you're still driving, but you can't see that. And it ended up being the optometrist who was the one who said, no, she can no longer drive. And I feel that the doctor that my mum went to needed to have considered the ethical dilemma and discuss it with someone else before he was making the decisions, because it was concerning us that my mum could hurt herself or someone else. So this ethical dilemma one is one that we can all identify with. So I really do suggest that you use perhaps this in that example page that you've got. So ethical dilemmas are a standing agenda item for team meetings. This ethical dilemma was discussed and a solution was identified at a team meeting, and it was decided that the doctor would discuss his concerns with the patient and other options or services available to the patient, such as taxi vouchers, Uber, family members, community transport. So how this is then able to be passed at accreditation is that if I can see that there's been a team meeting discussion and minutes have been done and what the outcome was, that the doctor has made a recorded note about the discussion with the patient, then to me they have met the intent of the meeting, that ethical dilemmas are discussed and recorded and noted. Okay. Now, business plans, another new one, very different. I was very fortunate to be able to do the pilots of, just excuse me again, I do apologise. My apologies. I'm struggling with a silly throat today, so I do apologise. Business plans. When I was doing the pilots for the changes from the 4th to the 5th standards, we got into a lot of discussion about the business plans. A lot of the doctors felt that this was an area that was not really something that needed to be shared with surveyors, junior staff members, reception staff. And a lot of discussion was as to why do I need to see a business plan about how you're setting up your practice and what your goals are. We've got here a template, and this is part of our clinical governance. And the idea is that we're trying to design a clinical governance framework for the practice. And so we're looking at an environmental scan as to what, why we're setting up our business, what our thoughts are, and we need to rewrite a document on this. It's not the same as doing a business plan for the bank, where you're putting down, well, this is what we want and this is how much we need to borrow. It's nothing like that. It's actually managing the safety and risk of your practice. So the indicator that we're talking about now is C31C. Our practice has a business risk management system that identifies, monitors, and mitigates risk in the practice. So the intent of this is that we're managing safety and risk as part of our quality assurance, that clinical risks clearly need to be managed, but so do business risks, because if the business fails, the practice isn't able to provide clinical care. A risk management process helps to consistently identify, document, and manage clinical and business risks. So you must, again, we've got our musts here, you must maintain a documented risk management process, and you must develop procedures to mitigate these risks. You could maintain a risk register. You could maintain a log of risks if you're a small practice. You could keep a record of meetings where risks have been identified and actions agreed to manage those risks. Now, your practice manager will, in her interview, be asked, how do you identify, monitor, and mitigate business risks in the practice? And the process is that you need to, as we say, maintain a documented risk management process and develop procedures to mitigate risk. Now, my practice underwent its accreditation under the 5th standards 3 weeks ago. And this one took me a lot to get my head around as to what were the standards asking, what information was I able to put down, what information was going to meet the criteria, and what was my practitioner going to be comfortable with me doing. So even though I'm a surveyor, I have my own practice that I need to maintain the same standards that you need to maintain. And some of these things do take a bit of thinking. And so I put down on my template, using the suggested template in the slides previous, things such as that the risks that I had identified is that we needed to be maintaining, obviously, doctors within our practice. But I'm at the moment working in a little solo practice, and one of the big things that is a concern for our practice is the work-life balance of our doctor and maintaining her health to enable her to be at work to see her patients at the same time, managing her family expectations. So we did our risk register on how could we ensure that she had adequate time off, that I don't know about your practices, but the area where my practice is, we struggle to get locums. So this was the line that we went down and looking at, because to me, that was a risk that we had in our practice, and our business plan needed to work on that. We also identified that we needed to be reviewing and having a quality improvement process of going back and looking in 6 months' time that those suggestions that we've put in place on our business template, we're not going to just ignore them now for 3 years, but in 6 months, we're going to have a look and see if we have been able to manage what we're doing, to look at ways to improve that. So that's the kind of thinking that we were looking at in our practice. We ended up looking at such things as the doctor's health. We looked at the health of the staff. We looked at the costs involved in how much would we lose if the doctor had a week or 2 weeks off. So we obviously can't earn an income. So a whole lot of things. So it's ended up being quite an interesting activity. So I just want to encourage you that it's actually not as difficult as I originally thought. We also, as part of this, we have to evaluate the progress towards the goal. And that was why I put in my sheet that in 6 months we would have a look and see what had happened, what was the intent, suggestions of evidence, and what should be included. So we set up on ours that coming up, the Easter break that's coming up, that our doctor will be having some days before Easter off, so that she actually gets a longer break than just the Easter time. How much income we're potentially going to be losing in that time. But at the same time, we also looked at having other services that we would be able to do whilst the doctor was away to ensure that we were going to be keeping up with our goals and our finances. So I will now be evaluating in 6 months after Easter, and I'll probably come back and say it worked or it didn't work. But that's the way I looked at doing this. So I hope that helps and encourages you on how this business plan risk is working. C31B, it's again non-flagged. So the intent is that we're maintaining and improving the quality of care provided to our patients. Our patients aren't going to get good care if they've got a very tired doctor in my practice. The practice team worked together towards the common goal, so we were all aware that we needed to allow our doctors some downtime so that we could look after our patients in a better manner. We then decided evaluation would be in 6 months' time, and then our business operations systems, they were ensuring that we promote consistency, continuous quality improvement, and quality assurance. So in discussions with the surveyors that came to my practice, they felt that this met all that particular criteria. So it doesn't have to be a difficult plan, if that's helping you with some thoughts for doing your own. So there's no you must on this, no you must at all. It's all a you could. So what works for me in my practice is different to what will work in your practice and the practice next door. So we maintain progress reports against the business strategy or the action plan. We've created a strategy for continuous quality improvement, and we've looked at some improvement initiatives that we can work on to tick all of our boxes. We will be asking when we come to your practice, do you evaluate the progress towards achieving your business goals? So obviously when I had my accreditation, I'd only just set up in January the goal, and it's going to be evaluated in 6 months, but I had my template and my next lot of paperwork ready to go, so that if you can show me when I come to your practice that you plan to evaluate this in 6 months' time, or that you did evaluate it, then you have marked met this particular C3.1B. It's not flagged, but you've still marked it as met because you've worked along the process of evaluation. C31C, which is flagged, Our practice has a business risk management system that identifies, monitors, mitigates risk in the practice. So all of these are actually, the one document covers all of these different indicators. So you don't need to have 3 or 4 different documents to be able to tick a number of indicators in this particular criterion. So we go back to the same intent. Managing safety and risk is part of quality assurance. Clinical risks clearly need to be managed, but so too do business risks, because if the business fails, we can't provide our clinical care. A risk management process helps to consistently identify, document, and manage clinical and business risks. And we must maintain a documented risk management process and develop procedures to mitigate the risk. So, same thing again, and these are flagged. Maintain your risk register, log of risks, keep a record of meetings where they have been identified and actions agreed on to manage those risks. So remember I mentioned that with ethical dilemmas, I've added it as an agenda item on my meetings. We now have added this onto an agenda item in that we've got risks discussed. There may not have been any, there may have been some, but we all identify what may happen, what can happen, what could have happened, and how will we address them. So that then ticks boxes. So management interview, how do you identify, monitor, and mitigate business risks in the practice? And if you're able to show me a documented risk management process and have procedures set in place to mitigate them, i.e. discussion at practice meetings or someone doing different audits, I'm able to say net when I come to your practice. Business risk management systems. The Australian Commission on Safety and Quality in Healthcare notes that good practice governance is participatory, consensus-oriented, accountable, transparent, responsive, effective, efficient, equitable and inclusive, and compliant with the legislation. So all of these things we have discussed tick all of these boxes. The business risk management systems that are likely to impact practices or types of business risk are conflicts of interest, which we briefly talked about, workforce planning, unexpected sick leave, unplanned emergencies, and updates to the IT security system. Here in Sydney, we've been having a lot of thunderstorms, and 3 weeks ago, one of my RAID hard drives blew up big time. We just got it fixed and replaced when we had another lot of storms. In the middle of all of this, we've now had 3 lots of storms that not only have put out my IT system, but also my fridge, my cold chain. So I now have different items on my risks that I need to be looking at because of the constant storms that we've been having up here. A business risk management system needs a risk management strategy, a strategy that identifies and analyzes, evaluates, and explains how risks have been managed. So the risks may be poor record keeping, failure to check patient's history when writing scripts, lack of documentation of the consent process, equipment that is not maintained in accordance with the manufacturer's recommendations, and inadequate number of practice staff working during busy times. You've probably all seen a risk matrix. These are quite good to sit down, and these are what my girls have a chuckle. We sit down and we look at this in our meetings if we haven't got anything particular and we think of something that may be. With these storms, we ended up having to say that, for instance, the power going off and being off for a long period of time all of a sudden has become very likely, and therefore it's quite significant. So it's quite high because it does leave us with an issue of no vaccines, no fridges, and our PHU up here we can't order our vaccines immediately. We have to wait for a number of days. So we have to then cancel our patients and rearrange a lot of appointment times to manage what's been happening with thunderstorms that are outside our control. But I need to now look at the risks that and the ways that I may be able to manage this, because it's become a significant, severe, and very likely. Obviously, I now have to be looking at different generators and different power supply sources, because it's starting to happen a little bit too frequently up here. So, how to meet requirements of business risk management systems. Again, this risk register to record the problems that could result in the risk becoming a reality, the matrix, a risk management strategy, the procedures to mitigate the risk, a record of the meetings where the risks have been identified and managed, and document the implemented changes when the potential risk has been identified. And I'm sure you will have lots and lots and lots of other thoughts and ideas yourself to be able to put this all into place. Just before we move on, I was just wondering, just because is quite heavy what we were talking about the business plans, has anyone got any concerns or any questions that they'd like to throw out now on the first hour that we've had, or any queries that we can discuss before we get into the next half? So Tanya, if you've got any questions anyone might like to ask, or that you'd like to ask on their behalf about the business plans, is everyone comfortable with that?
Everyone looks to be pretty happy in the room. No questions at this stage, but maybe later on.
Okay, just as a heads up, I was just briefly talking with Melanie, and if anyone would like a copy of the template that I've put together at my practice, I'm more than happy to send that to Melanie for her to be able to share that with you all, just as a starting point, to give you a bit of an idea on the type of things you can look at. If that would be of help to anyone, I'm quite happy to do that.
Yes, lots of nods, Chris. Definitely.
Okay, excellent to hear, because one of the things, I don't know if you're all aware, but to be a surveyor, we have to have our practices. I have to have my practice to be accredited. And I tell you what, I tell all of you guys, don't stress about the 5th standards. And then I needed to tell that to myself when it came to preparing my practice. But it actually was easier than 4th standards. I felt that the change from 4th to 5th is a positive one for us all. I feel that because we can do it in a manner that suits our practices. There's a practice that I surveyed last year, just the last tail end of the 4th standards, and they had decided to, they could have done 5th without any problem, but they had a very large practice, and in their waiting room they had like you know how you have those boards, not a whiteboard, but the paper sheet boards that you write on when you're at a workshop. And they had asked, they left pen there and suggested that that was how their patients could do feedback to them. And it was a completely different way of feedback. And so patients would come in and they'd make comments, and they had one side was for the positives and one side was for the negatives. And it took them a while to encourage the patient to actually write on these boards on different things, because they felt then they could discuss them straight away. And I'd not ever seen anything like that. And I thought, what a brave practice, a really brave practice. But it was just something that they felt was the way in their little community that they felt it would work. So with the new standards, just try and have a good think of what works for your practice. So in the practice that I'm in, we didn't have, well, they had an old web page, an old sort of, I think it's about 10 years old, and nothing had ever happened to it. And I inherited this practice a couple of years ago. So we worked very hard to put up a web page that meant that our practice information sheet would be always on there. But I also decided I wanted to have the opportunity to put, for instance, it's coming up to the flu season, to say, okay, this is what we're doing. This is when our clinics will be, our flu clinics. and different things to try and engage the patient. It's something new for the practice that I'm currently supporting. And it's sort of just looking at things that suit our practice. So I really want to encourage you all that the next lot of accreditation is about your practice and how you get your services to your patient in a manner that works for them and for you. So we're not sort of stuck in this black and white of you must do this, you must do that. The musts are easily managed. Okay, so if we've got no questions and you're saying yes, I'll make sure I send that template to Mel and we'll move on. So this one about the use of email, the very beginning, the very first one, C6.4 flagged F. Our practice has a policy about the use of email. So we need to look at what the intent of the indicator is. We need to look at suggestions of evidence, what should be included in the evidence to meet the intent of the indicator. So I'm just going to read, please excuse me, I just read this. So the college, the RACGP say that maintaining the privacy and security of health information held by the practice is a legal obligation, and it includes maintaining computer security. Practices are increasingly using electronic forms of communication to convey information about their services to the public and their patients, and therefore practices need an email and social media policy. You must maintain an email policy on your practice's website, have an automated response to patient emails that advises them of when they are likely to receive a response. So the practice must maintain an email policy. We have got some different tips here. I don't use email to my patients in my practice. It's something that I find a little bit worrying. I have had the opportunity to sit on some workshop panels with Avant back in the earlier days of social media and emails. And one of my concerns, my personal concerns as a manager, is the patient that's going to send me an email and say, oh, I'm having chest pain and I need to see the doctor now. And my girl's not reading the email until tomorrow morning. And the patient subsequently has passed away and I'm held liable because we didn't deal with it immediately. That is going a little bit over the top, I understand, but that concerns me as a manager on being able to control what information is going to come into my practice. So as my slide says, it is not mandatory to implement communication via email. And if a practice chooses not to use email or social media, they still require a policy which would state they do not use email or social media. If email communication is implemented, a policy is required to demonstrate consent from the patient for the communication via email, and evidence is required that the assigned email address is correct. So in my practice, we use email, of course, but we don't encourage emails from our patients. I've actually removed our email address from our website, from our business cards. I've removed it all the way along. We do ask our patients for their email address. We get them to sign on their patient registration form that they're happy to use email. If we do have to send something via email, we always phone the patient and confirm the email that we're sending it to and advising them that the email communication to them is not encrypted, and so therefore it is available for other information. And I sort of feel that that for my practice is enough. Now, I have been working with other practices that everything is via email, and they have a paragraph that clearly states there is no patient bookings, no emergencies, no nothing to be communicated via email. So you need to ensure that you've looked at everything when you're looking at your email, and your policy needs to state very clearly exactly what it is that you're doing with regards to your email. It's just something that I personally am concerned about, but then you can see by my grey hair, I'm an older generation, so I'm still getting my head around the social media communications that our young people like to use. Social media is another one. Our practice has a policy about the use of social media. Please excuse me again, I'm going to have to mute you. I do apologise. The intent of the indicator, suggestions of evidence, and what should be included in the evidence to meet the intent of the indicator. So the social media one, pretty similar to, I guess, your email one. So we have, let's bring up my notes here. We have evidence that we need to be looking at. We need to think about engagement on Facebook. You need to think about Twitter. You need to think about Instagram. We need to also look at with social media comments on Facebook and the policy of our staff replying to those comments. We need to have a policy around controversial topics, example, vaccinations, and you need a designated communications person. So when we start going down these roads, we need to be really looking at other information. As you'll see here on this slide, we've got, the college has got a document, the guide for the use of social media, and there's also the AHPRA's social media policy. Now, these two documents are something that I feel we as managers and business owners, we need to be really very aware of what the government and the college requirements are in using these particular platforms. We need to be very, very careful that we're not leaving ourselves open for any concerns. It's a little bit like if we put photographs of our practice on Facebook or Twitter or Instagram, and we have a patient in the background who we have not asked permission to put that photograph up for public viewing, we can get into lots of bother. I was at a practice last year. It was a new practice, and the young son-in-law of the owner of the business was very much into social media. So he'd taken all these lovely photos of the practice and all the patients that were sitting there, and we got a letter from one of the patients, absolutely dreadfully distraught, a letter also following very quickly from her legal people. And her photo had been put up on Twitter, and she was actually in a, sadly, a domestic violence situation. And she was hiding from from her old partner, and was found because of the information that was put up on this website. So this practice then got themselves into quite a lot of bother because they hadn't sought her permission. They had just put it up there. It ended up being quite messy. So these are things we don't normally think of. And I just want to encourage you to be very, very, very careful and make sure that you're very aware of the guide for the use, social media policies, and be very mindful of what we put up is out there forever. We can take it down, but somewhere someone's going to be able to still access that information. It's the same as if you have a patient that makes a comment that may be not supportive of your practice, and you have a staff member who may respond in not a very supportive way. Again, we're starting to have breaches of confidentiality and a lot of privacy issues. So that's just my personal heads up warning in being very mindful before we jump in and say, yes, this is great. Have a policy that protects you, covers you, that all staff are aware of, all staff sign, so that you are understanding, that they're understanding what we've talked about in that there are some downsides to using all of this media. Is that helpful? I hope so. Now, back to quality improvement. So we've talked about business risk management. Now we're going to talk about clinical risk management. Now, quality improvement module, new indicator. And we may say that, hang on, clinical risk is something that we've all already talked about. There's new concepts that we need to focus on. And this is one of the new ones, because part of our quality improvement on clinical risk management is this QI 3.2a. And if you look there, there is not a flag next to the indicator. And it says that our practice follows an open disclosure process that is based on the Australian Open Disclosure Framework. Now, open disclosure, the same as ethical dilemmas and business plans, this is all very new thinking that we are asking you to get your heads around. This is not a mandatory indicator. It's just introducing the concept. And as I mentioned earlier in our afternoon, that things that are going to eventually in another standard become mandatory, we are introduced to it as a non-flagged item. It's a little bit like our equipment, our treatment room equipment. So for instance, we don't have to have a defibrillator. A defibrillator is not flagged in our list of equipment. It's there in the list. So it's aspirational, but it will become mandatory down the track. So these ones will also become mandatory, if that helps to explain what we mean by flagged and non-flagged. So our practice follows an open disclosure process that is based on the Australian Open Disclosure Framework. What is the intent of the indicator? What evidence could meet the requirements of this indicator? So the intent, communicating openly and honestly, is important for the patient to move on, to develop better relationships with clinicians, to be able to be more involved and take some responsibility for their own care. And in this, there is no you must. You must doesn't sit there at all. The evidence that we've got down here, we've got you could maintain open disclosure process and encourage all the members of the practice team to follow the process. You could develop and implement policies and guidelines that align with the Australian Open Disclosure Framework. We could have a risk register, letters of apologies that have been made, different policies that we've put in place, records of apologies, induction, education and induction. It's a whole bunch of different things. And in the new standards on page 107, it actually gives you quite a lot of different information to be able to follow other ways to manage this. The definition of open disclosure is that it's an open discussion with a patient about an incident that resulted in harm, could have resulted in harm, whilst the patient is receiving health care. And the element of open disclosure is that an apology or an expression of regret, which should include the words "I am sorry" or "we are sorry," have been used. A factual explanation of what has happened, an opportunity for the patient, the family, their carers to relate their experience, a discussion of the potential consequences of the adverse event, an explanation of the steps being taken to manage the adverse event and to prevent reoccurrence. The college has endorsed the Australian Open Disclosure Framework, and that's been developed by the Australian Commission on Safety and Quality in Healthcare. And this is something which, again, we need to perhaps download and have a good read of. So the guiding principles from the Australian Commission on Safety and Quality in Healthcare is open and timely communication, acknowledgement, apology of expression of regret, supporting and meeting the needs and expectations of patients, their families, their carers, supporting and meeting the needs and expectations of those providing the healthcare, integrated clinical risk management and systems improvement, good governance and confidentiality. This is the document that we're talking about. My apologies again. How many times do we hear on the news, discussions with friends of people who say, well, they didn't ring up and apologise. All I wanted was for someone to say, I'm sorry. Once upon a time, we used to be told, say you're sorry, you're admitting liability. No, we're not admitting liability. If you stop and think about it, an apology is not intended to be and shouldn't be seen as an admission of liability or a statement casting blame. All jurisdictions in Australia have apology laws, statutory provisions that protect statements or apology or regret made after an incident from subsequent use in various legal contexts. An aim of this protective legislation is to create an environment where doctors can feel comfortable expressing regret to their patients. So if you are involved in an incident involving an adverse outcome, you should be aware you do need to notify your insurer, but we really need to have the freedom to say, I'm really sorry, it was not our intention to cause hurt, harm, distress, all these different things. I get amazed once I started sort of looking into open disclosure as to actually how many times when the journalist is interviewing the patient, interviewing someone after an incident has happened or something's happened, and they just say, well, no, can't they just apologise? And oftentimes the apology is all that's needed and an explanation. They're not looking to blame everyone. I try to teach all my staff in all my practices that I support that the idea is I want you to let me know what has happened, not so that we can say you did wrong, but so that we can look and say, how can we fix it? How can we avoid this happening in the future? How can we make improvements to our system to allow us to move on and to allow the patient or whatever has happened to move forward? Are there any questions just before I move on from that? Tanya, is there anyone got any questions with regards to the open disclosure?
My only question is if afterwards that links can be sent to us, you can kind of read it.
I can't hear, sorry.
It's just a question whether we can send the links around to the participants that you've referred to in the document, because they're a little bit hard to read.
Okay, yes, did you get a copy of the, you did, I'll mention that to Melanie, Tanya, that those links, because it would be good. I was invited to go up to Darwin last year to Top End Health, and we did a 2-day workshop, and a whole day we spent on the open disclosure and ethical dilemmas. Now we've sort of putting all of this into just 2 hours. And it was quite interesting because we all sort of think, well, you can't say you're sorry and what it's about. And the link is actually quite good. It has quite a lot of information in there. So I will make sure that that's sent to yourself so that you can pass that around to your participants this afternoon. That would be excellent. So yes, we can do that. Okay, as we talked on before about the new indicators. So we've got the qualifications of our clinical team. We've got this new one, and I need to tell you a little funny story after I read this down. GP 3.1 flag C. Our clinical team is trained to use the practice's equipment that they need to properly perform their role. GP 3.1D. Our clinical team is aware of the potential risks associated with the equipment they use. Now, earlier this year, so just taking a step back for a moment, I don't know how much information you all have about myself and my role, but I'm a certified practice manager. I'm a consultant practice manager, and I have had 25 years experience as a practice manager in a practice in the Blue Mountains. But about 15 years ago, I started doing consulting work. And so I often get given a large lump of concrete and told we'd like to put a practice on here, all the way up to we've employed staff and we don't like them anymore and we want them to go. So I look at a lot of different facets of practices and support a number of practices. And there's one practice that I support that was going for the fifth standards, and we were doing a mock survey. We were going through the questions with the doctor and the nurses. And the doctor said, who's going to teach me how to use the equipment that I've been using for 20 years? Why do I now need to show evidence of my training when I've been teaching everyone else how to use it? And he was getting himself quite distressed about this. He was quite unsure of just how he was going to manage to get this part of the training sort of organized. And he kept coming back to him saying, I teach the nurses. I bought the equipment. And I was trying to explain to him that we understood he knew how to use the equipment. We're not saying you don't know how to use the equipment. We're just saying that you need to have noted down that you do know how to use the equipment. He wasn't happy with that. He went on and on. We wasted nearly an hour on these two tiny little criterion indicators on how was he going to be able to show that he was properly trained. He wasn't going to pay to get the companies to come out and teach him, because those companies probably didn't even exist anymore. And I have to be honest, the equipment probably needed updating anyway. So the way we manage this one, so this is my heads up for all of you. In your induction sheets that you do for new staff, make sure you have added that they are needing to be trained. It would be a good idea to have your doctors and your nurses and your staff all together in the room with the equipment that they already know how to do, and just make sure that the doctor does some training with the staff in saying, this is how we use it. Does anybody have any queries, any discussions? The doctor is busy, ask your nurse, if not yourself, the staff. Just all get in there, have a hands-on and tick in your training schedule that you have discussed and the staff have been using this equipment for the last 20 years, whatever long, and that all new staff to the practice will be trained to use the equipment. That's what we did at my practice the other week. And my surveyors had a bit of a chuckle because they said that everybody is getting themselves all concerned because a lot of the equipment is old equipment. So don't get worried, don't get puzzled. It's actually quite easy to get your heads around this one. Okay, so we do need to be aware of the potential risks. I think there's more of an issue with everyone knows how to use the liquid nitrogen, but are we aware of the risks of using the liquid nitrogen? So I wouldn't be too worried, but you do need to make sure you note down that you've discussed how it's used. You don't have to pay for someone to come in and teach you how to use it, but when new staff come moving forward, you need to have this in their induction. GP 4.1F, our practice records and the sterilisation load number from the sterile barrier system in the patient's health record. And the sterile items have been used and records the patient's name against the load numbers in a sterilisation log or list. Now, those of you that are doing sterilisation in-house, you're possibly thinking, well, we already do this. So what we had been needing to have had done previously was that we would write the patient's name down next to the load numbers, but we weren't necessarily always putting it into the patient's file. So if you're using some of those little sterilisation kits with the little gun and the little stickers and that makes it simple for you. Otherwise, you need to be making sure that your load numbers are noted next to your patient's name and vice versa. You can see it's an unflagged indicator, unflagged one. So it's something that they're going to give us time to get ourselves sorted with. If you're not doing sterilisation in your practice and you're using disposable, you don't need to be worrying about this one, but it's only for those practices who are still using their autoclaves. And the one that I mentioned earlier, the medical practice, GP 5.2E, our practice has a defibrillator. We don't have a flag there. A lot of practices have had a defibrillator for many, many years. Those that don't, we don't have to. But what it is suggested in the standards, anything that you have that doesn't have a flag, you need to have a look at in your standards as to the reason why you've come up with the decision not to have a defib. I was at a practice last year and the doctor there said, oh, we don't have a defibrillator because they were in a shopping centre. And he said, the shopping centre's got a defibrillator. And I said, and where is that defibrillator? Oh, I don't know, but the shopping centre's got a defibrillator. I said, so by the time the patient has collapsed and you've realised they need a defib and you've gone to the management office to find out where the defib is, you know your patient has died. And they just looked at me in absolute, it never occurred to them. So defibrillators are something which they're not mandatory, but you need to have a good discussion as to would you use one? Have you used one? Can you access one? How long will an ambulance take to get to your practice? If you're in a shopping centre, do you have to go down 3 floors and around the corner, or is it just outside your door? So these are the kinds of things that is, I advise that you have a think about. With the new standards, we've got practices that are saying, if I just do all the things that have got a flag, the musts, and I don't do any coulds, will I still become accredited? Not really, because you're not showing that you're wanting to be the best practice that you possibly can be. There's a lot of, in the you coulds, that if you pick out a few of the you coulds on meeting a lot of the standards, a lot of the indicators, then you know that you've done everything you possibly can to be the best medical practice in your area. And isn't that our goal? We want to make sure our patients are safe. We want to make sure that our patients are being cared for properly. We want to ensure that our in-house systems make it simpler for us to do. So it's a case of having to have a good look at why you're not having a defibrillator, why or how are you doing your sterilisation, all those new things that we've been talking about today. It's a case of don't just do the bare minimum, because the bare minimum will not automatically ensure that your practice would be accredited under 5th standards. You need to do all what you need to do and a little bit more so that your surveyors, when I come to your practice, I'm able to see that you understand the reason why we're doing this safety and quality issue, why we're looking at these standards in the way we are. As we know, the PIP and the PNIP and all of those things are changing this year. We've got lots of changes happening, and the focus is going to be on quality improvements in our practices. And a lot of the things that we're asking you to look at in your 5th standards is actually quality improvement activities. In my meeting notes again, my agenda's become quite long now, I've added quality improvements in the practice because we haven't gone into it here today, but one of the particular indicators that we have to look at is our team, our staff. Are they given the opportunity to put input into the practice on quality improvements? Are they being told about quality improvements? Are they part of the process in managing all of these different things? And you sort of look and think, well, if we do this in team meetings, we have to have a meeting. We may as well tick all the boxes while we're at the meeting. The other one, which I actually didn't have, and I didn't get a MET tip at my accreditation, was that we also need to make sure we're talking about our work health and safety issues. They need to be noted on our meeting agendas as well. So a lot of these things that we've talked about, if you make sure that you've got them there on your agendas to just briefly ask, are there any work health and safety issues? Are there any risks that we've got to worry about? Has anyone got any ethical dilemmas to talk about? Do you have any concerns about open disclosure? Have you got your head around the fact that I can have a bunch of flowers as long as the bunch of flowers doesn't come with you must see me at 2 a.m. in the morning? All of these things are going to assist in you working towards your quality improvements that we're needing to do now to be able to entertain some extra funding from Department of Health and Ageing. Do we have any questions? We now have quite a bit of time. The first time that we did this webinar, we found we needed a substantial amount of time to discuss questions or to answer any queries that anybody may have. Doesn't necessarily have to just be about what we've talked about today, but anything to do with the 5th standards. Whilst you have the opportunity and you're all together, ask me whatever is causing you concern or worries or things you're not too sure of. Your person sitting next to you may be wanting to ask the same questions, but isn't brave enough to ask. So this is where I can turn our meeting over to you guys to see what it is you'd like me to give you some support with.
So I have an mentor accreditation page for the people. If you get an unmet, how long do you have a time frame?
I can't hear, perhaps, yep.
Sorry, Chris. The question was if there's an unmet, how long do they have to address that?
Okay, so we have what we call natural justice. So we've come along and we've gone through your practice with a fine-tooth comb. And those of you, if there is there anyone who hasn't gone through the accreditation process yet in the room, Tanya?
Quite a few. We've got a few new practice managers.
Oh, oh, well, you guys, ask away. So this is what I love to do. The whole purpose of accreditation is that we're not coming to say you're good or you're bad. No, 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 no. We're coming in alongside of you to support you in maintaining a particular set of standards, which the college have put out, which now is the 5th standards, to enable you to know that you're doing everything according to what is recommended, and to enable you hopefully to get some extra funding. So it's not a test. We come in, I walk in, sit down. The first thing we do is we sit down and we say, tell us about your practice. We have a wander around. We say, show me the treatment room. Show me your practice. We don't open any doors that are locked, closed. We don't need to stick your beak in areas you don't want us to see. But we come in as if I'm coming into your lounge room. So look at accreditations that you've invited a couple of old friends to come in, sit down and to have a look around your home. We then have documents that you can upload. You can put on the portal some different documents, but even if you do that, I will still ask you to show me those documents. So I will have had a look at them before I come, but I also want to have a look at the physical copies that you have in your practice. I personally like to sit with the practice manager or the senior receptionist and do this as a team. I don't like being shut in a room and just having to look at everything, because you know where things are and you may have a different way of showing me all your information. We then work through a series of questions. As you know, if you've seen your accreditation pro, the doctor will spend about half an hour, 3/4 of an hour with my co-surveyor, who is a doctor. So they do the clinical side of things and I do the management side of things. And they will discuss pretty much the same type of things that I'm going to discuss with the reception staff and the practice manager. We then start going through documentation. If there's something that I can't see readily, then I give you the opportunity to find that. You might say, oh, is this what you're talking about? Because the language that is used in the standards or in the accreditation survey, maybe you have it under a different name. So when I talk about a business plan, your practice may say, oh, that's our strategic plan. Or if I talk about a QI protocol, you may say, oh, we've got a list over here of all the things that we've done to the practice over the last 12 months. This is where we sit down and we say, well, show me what it is you've got. And I'd be able to say, yes, that meets that. And oh, this one doesn't quite meet. So whilst we're there together, I would then say the way to meet this and give you examples. And you might say, well, actually, we're doing that. So an example, let me think, we could use. We'll go back to the thinking of when we're doing performance appraisals. So we used to have a very formal performance appraisal. We still need to do performance appraisals. And you might say, look, I haven't got all those documents, so I mustn't meet that. No, I would say to you, so do you have a meeting? Do you sit down? Do you talk about it over a cup of tea? Do you have tasks that you would like your staff to meet, or different things to meet? I'm going to have to mute you all again. I'm sorry.
Is that answering your question?
Yeah, it will. Yeah.
Sorry about that. So you have the opportunity to say, well, I'm not quite sure what you mean. We do this. So we look at everything. If we still can't find the information and we have to mark it as not met, that information then is obviously at the end of our visit, we upload the report to AGPAL. And usually within about 7 days, you'll get an email or a call back from AGPAL, and they'll say, the surveys have been, and we note that you didn't have the documentation that was required for this, this, and this. You then have the opportunity within a week or 2 weeks to be able to get that information to AGPAL. So let's say, for example, CPR. So one of your doctors has not yet done their CPR, and they're booked to do their CPR on a particular date. As soon as you get the certificate or get a note that says that they're booked in for CPR on a particular time frame, you would send that information to AGPAL, and that's in what we call the natural justice period of time. Or you've got a doctor that didn't bring in their ARPRA certificates or something like that, to be able to show that you have met the criteria, met the indicators. Your file then goes to what we call the report writers. And by the time it goes to the report writers, if there's still no evidence of you having met certain indicators, you then have what we call working towards accreditation. And you have a 2-month or so period that you must have that information supplied to AGPAL. Now, when you do your accreditation, it's a 3-year system, but we usually meet you around, try to come and do your survey about 3 months before you're due to have your survey visit, before your certificate runs out, and that's to give you time to fix up anything and us time to get the reports back to you. So once upon a time, we used to be able to offer extensions. We can't offer extensions anymore. It's a case of if you don't have your accreditation by your due date, you lose your PIP payments for 3 months. So we try to do the visits as early as we can to make sure there's time for you to meet those possible unmet areas, to give you time. But we also make sure that when we leave your survey visit, we've left you with the tools to be able to put that into place, to implement that. With your feedback, usually when I go into a practice, the first things that I ask the practice is, have they managed to do their patient feedback survey? have they put up their information on the wall of what they were discussing? And the other one that I usually find that's missing is for your cold chain, there's a self-audit that needs to be done. And I usually ask those at the beginning of the visit, because we're usually there for 4 hours, 3 to 4 hours at least, to give you time that whilst I'm there, you can actually fix up those things that are missing, and you can have a look at what might need to be done. And that gives you time then to work out, not explaining well. So you can complete those tasks before I leave, then I can mark you met. Does that make sense? Does that answer the question?
Yes.
Yes. Yep. Nods all rounds.
Okay. So that's how I do a survey. So I know we all get very distressed. I'll tell you a little chuckle. I left the practice I'd been 25 years working in after the second accreditation, and vowed and declared I'd never do it again. And into doing what I do, and now all I do is accreditation. So, it is a stressful, and I'm not going to say it's not. It is a time that everyone gets anxious and stressful, because we want to present our practice in the best light. We want to present the practice as being up there amongst the best practices, and to have someone coming in with a critical eye is very daunting, and that is why we have to make sure that we as managers are working in practices so that we know what you're going through, and the doctor has to be working in a practice so he knows what the doctor is going through. So it's what we call peer-to-peer review. So it's your peers working with you. It's not a test of a pass or fail. And everything is done to get you over that finish line with a positive.
We had another question.
Yep.
I would like the best suggestion on after accreditation between that and the next one. What's the...
Sorry, Tanya, please. They're very muffled.
Possible.
Yeah, I'll repeat the question back to you, Chris. Sorry, I'm going to have to get you to repeat it.
Between, what's the best way of operating your practice?
Sorry.
So
It's not going to happen.
the question, Chris, was in between accreditation visits, what's the best way to operate the practice and to make operational improvement?
So
to make the next accreditation easier. I can see
so,
you've got green.
Yeah.
So so the ideal, in an ideal world, so these systems that we put into place, if we keep following, so if we've already got, so our new staff members arrived and we've got our new staff pack, I'm sure all of you have sitting there as a template. You just go click, 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 induction, this. So you make sure that you're doing everything the same for every single staff member who arrives. Instead of thinking, oh, staff member turned up and I didn't do the induction, I'm going to need induction for accreditation. So you start thinking about, well, this is the process that they're going to ask me for. Every new doctor that comes into the practice, or every doctor each year, you need to be saying, I need a copy of your indemnity, and I need a copy of your APRA, and I need a copy of all of these things, because when accreditation comes, you're going to have to show that to me. So if you are in the process of doing that every single 12 months, you know you're up to date with your information. CPR, right, our CPR is due in June of 2019. So the doctors have to have theirs done every year, but we don't need ours done for every 3 years. So maybe in 2 years, I'll get it done every 2 years, so that when accreditation happens, we're not thinking, oh, we didn't do our CPR. Our quality improvement activities, as I was talking about with the business plans, the business risks, and all that new stuff that we've been talking about, it's a case of, if you put in reviews that every 6 months you're going to go back and going to review that, you're going to update that, then you're only updating and reviewing a small section. You're not having to do 3 years worth of work. And by doing this continuously along the line, accreditation comes and you won't have to do anything different because you've just kept carrying on exactly the same all the way through. And there are practices that do that, and they say that every year they get their IT guy to check their security and information stuff, and they do a review. We've got people who look at the policy and procedures. So just as an example of policy and procedures, when I go into a practice as a surveyor and I'm handed a brand new policy and procedure manual that was printed off, it's still warm that morning, I groan. I think, oh no, I don't need you to chop down trees. I don't need to have all of that. But if I'm handed a policy and procedure book that started about 10 years ago and it's dug in and it's got papers added in and bits over here, or I'm shown online where it's all been reviewed and updated and it's on the shared drive, I think, great. They're working on this all the time. You're understanding what I'm saying? So something changes and we put it in straight away and we deal with it instead of thinking, oh, I've got to do a policy and procedure manual. I don't have to see a paper policy and procedure manual. If you've got your protocols for your ethical dilemmas and all of these, and they're just in one small folder here, or they're all on the D drive or something, then I'm more than happy to see that, because a policy and a procedure manual is a living document. It changes, it grows, it moves, things change all the way along. That's how you can make it so that it's not so stressful. First time around, yes, I'm sorry ladies, first time around, it's a lot of hard work getting your practice to that point. But once you're at that point and we walk out, just keep working through and you'll find that next time round, you'll be glad to come. I find that there's questions that I need to ask, and it's what quality improvements has the practice made since the last accreditation. And I love hearing, oh, well, we've got painted out the waiting room and we put a kids' toy corner in, and we've got the new TV, and they go through all this list. And then they'll say, oh, well, we did a lot, but I can't remember. So each time something is done, go onto your computer, put down into your Excel sheet what you did and the date. And then when I come in, you're just printing me off or showing me, and you get a surprise that, gee, we did all of that. Another question I need to ask is about your data. How do you go through your data? What do you use, a pencat, or do, you know, different things? What do you do? And I love hearing all the different programs that practices are involved in, because you, the practice, are so enthusiastic about what it is that you're doing for your patients that you want to share that with us. And to me, that immediately ticks so many boxes, because it tells me that you are working towards being the best you possibly can. So I'm the same. As I get tired and I get weary, and my practices, sometimes things don't get done. And yes, my accreditation was the beginning of March, and I walked in. I had some reasons to not be at work for the week after, and a couple of weeks after, and I walked in and all the folders, everything was still there, nothing had been put away. And my girls had said, we didn't know what to do with this stuff. And I said, you're leaving it there because we're not putting it away, because this was the first time of the new standards. I said, we're now working on this. So last week we had our first of our meetings with my agendas, like I was saying to you, and all those things are down now. So we're just moving on. I hope I can maintain that, and I understand sometimes it gets hard to do that. But if you set yourself a goal of every 6 months you're reviewing your quality improvement, reviewing your plans, reviewing your clinical risk, reviewing those, you'll find that you'll be able to come to your next accreditation, and it won't be as onerous as your first accreditation. I hope that's sensible advice.
Yeah, that's great. Thank you, Chris.
What else have we got there?
Can't see any more questions, and we're probably running out of time.
Okay, then that's perfect timing. So thank you, everyone. Thank you very, very much for your patience with my coughing and my fiddling around with the screen a little bit. I thoroughly enjoyed my couple of hours with you. Thank you. And thank you for giving me the opportunity. And I will ensure that those links are sent to you, Tanya. and my template. It may be of some use, it may not be. Please feel free to use whatever you feel that is going to help, and maybe I'll meet you all one day.
Thanks so much, Chris, for sharing all of your expertise with us. It's been fantastic. We really appreciate it.
Thank you very, very much. Thank you. Thank you. Thank you to all of you as well. Thank you, guys. Bye now.
Bye-bye.
Bye.